patients in a hospitalist or medical setting need to assert themselves and need to come fully prepared to defend what they perceive as being the thing that's the problem. And even if they are wrong about what is wrong with them, that does not mean that they do not deserve to be treated with respect.
Welcome to Parent Footprint with Dr. Dan. I'm Dr. Dan. This show is about making the world a more loving, accepting, and compassionate place, one parent, one person, and one child at a time. The key to raising healthy and engaged kids is for parents to seek the same in their own lives while striving to be the best versions of themselves each day, no matter who you are or where you came from. With increased awareness, you can be purposeful about leaving a healthy footprint for your children, your family, and all those you care about, while living your own life to the fullest. Today's show is Reproductive Injustice and Racism with Professor Dána-Ain Davis. Dana is an associate professor of urban studies at Queens College and the Graduate Center at the City Universities of New York. She is the author of Battered Black Women and Welfare Reform, a contributor to Beyond Reproduction, and with Krista Craven, co-editor of Feminist Activist Ethnography. She's also the co-editor of Transforming Anthropology, the journal of the Association of Black Anthropologists, and she has a new book, which we're going to be talking about today, called Reproductive Injustice, Racism, Pregnancy, and Premature Birth. Dana, welcome to the show.
Thank you so much. I'm so glad to be here in conversation with you.
We have lots to talk about.
We do.
Where I'd like to start is for you to tell us a little bit about where you were raised, where you come from.
Great question. I was born in Harlem, New York, and I lived in Harlem right near City College until I was 8, and then my parents moved to an area of New York called Riverdale, which was a predominantly white community. And my parents have lived in Riverdale since 1965.
So what was Riverdale like then as you were growing up? And I imagine there's been some transformation over the decades as well.
There has been. When we moved to Riverdale, we were the only Black people in the neighborhood, not in all of Riverdale, but on our block. And we did experience various aspects of racism. My father's car tires were slashed regularly. But the neighborhood it ended up being a really interesting group of people. 3 people with whom I became friends, and we're still friends from the time of Sully and Susan. And a lot of political activism was taking place. My friend Susan's mom she would literally get us involved in politics. We'd be passing out pamphlets for presidencies and for mayors and that kind of thing. So it was both hard and simultaneously a very lovely political awakening.
This is such a common question. I know, I feel really important still to ask, like, what was it like being the only Black family in your area and how that did impact your identity development?
Yeah. Actually, it was hard, because first of all, I remember one morning when we were leaving, and the tires were slashed. And I think it was like the first time I'd seen my dad cry. He was just exhausted from that. And for me, the school, I went to a school. The first year we moved up there, my parents continued to send me to a private school.
Mm-hmm.
And then when I got into second grade or third grade, I went to the public school. And, the trauma was the names calling the kids used. But I think, I feel like what I learned mostly about being in that community was a commitment to justice. And it wasn't just being there. It was also my parents who were involved in various things like supporting the United Negro College Fund and the National Association for the Advancement of Colored People, and or the NAACP. And so I learned a lot about how you create community with people, and how people that may not be familiar with the kind of experiences you have, like racism, can still be good, committed people in a struggle. So, yeah.
Yeah, well, social justice has become a very a key part of your personal and professional life, and
Mm.
I'm curious about your road to becoming both a anthropologist and an ethnographist. And probably we should probably define. Could you tell us, help all of us understand these terms that we hear? But I also ask, okay, what exactly is that?
Yeah. So, essentially, anthropologists are people who are interested in all kinds of topics. A lot of people think of anthropologists as people who go and do research in other places. Like we leave our home country or our home community, and we go to
Egypt.
Egypt, or we go to Ghana, and we do, or we go to an indigenous community like the Crow Reservation, and we do that. But essentially, the way I perceive anthropology is that we're just looking to understand the meaning that people give to things in their lives. And so, but at the same time, we have people who are anthropologists that are really interested in things like water. Like, what does water mean? How do people use it? What are the ways in which toxins influence reproduction, or things like that? So that's what anthropology is. And that is, in fact, what I do. Some people have said the simplest version of understanding an anthropologist is somebody who's just kind of nosy and wants to know what other people are thinking and want to spend time with them.
Just a curious person. All right, you know what? We're gonna save, because I threw a lot at you. We're gonna save ethnography after we get through this, because this is your evolution. So what was the road for you to becoming an anthropologist? Like, did you know that this was a thing and something you wanted to do when you were young? You stumbled upon it?
It was completely an accident, literally. I have a degree in film. That was my undergraduate degree. And then I went and got a degree in public health. And I accidentally became an anthropologist, in part because I went to see the department chair of sociology, and he wasn't there for our meeting. And I got really annoyed. So I went instead to see the chair of anthropology. It turns, while I was getting my master's in public health, I had an anthropologist and a sociologist as professors, and they were each encouraging me to go into their particular fields. But the anthropology chair was there, and I liked her, and so I did it. And then I wasn't going to go because you needed to be full time, and I had a kid, and I couldn't figure out how it was going to work. And I said, I'm not paying to go to school, and then I got a grant.
Nice.
So it all worked out. But I'm definitely accidental.
Synchronistic. We don't know what are accidents or what are synchronicities. Right. So then the road to injustice, the road to actually ethnography and telling stories. Like how did that come to be?
ethnography is both a method and an outcome, a product. And so when you're training to become an anthropologist, one of the things that you can do is produce an ethnography, which is often a detailed description that's informed by theory to explain a particular set of circumstances. People write very dry ethnographies. Other people write tomes that are just impenetrable. And then other people write ethnographies that are more theoretical. And then other people write ethnographies that the general population can read. And I've always been very ethnographically inclined, I think, in part because I wrote poetry and had published and sort of performed poetry, and I had written a play that was produced by Greg Tate and Lisa Jones, who was Amiri Baraka's daughter. And just the sort of detailed process of writing to elicit emotions and feelings and telling people stories is something I've always enjoyed. And I think maybe the first, ethnographic interview I did was with my grandmother. I think I had like 8 hours of her telling her life story,
wow.
which was amazing. So the ethnographic approach that I use is life history or oral history.
Well, and that's what tells the story. And one of the stories that I recently read that you co-authored in this new article, A Birth Story, tells that story and the story of an experience and also of racism in a birth experience. I didn't ask you this before the show. I was wondering if you would read the poem that is in that piece because it's powerful, and it was powerful when I read it to myself, and I know that it'll be far more powerful if you were able to read it for us.
Oh, that's what an honor. But, I didn't write that poem. LeConte Dill wrote that. But now I have to pull it up.
Yeah.
So you're going to have to give
I'm
me
going to
a
give you a second because I didn't let you prep for that. This is going to be just a complete impromptu performance.
It will be.
And yeah, for everyone listening, this piece is about one of the co-author's experience, and also in with story and graphics about her experience, subtle and not so subtle, as we'll talk about, of racism that occurs, reproductive racism that occurs all the time as a matter of course in our country.
So this is a poem that was written after LeConte Dill, who is a public health scholar and a professor, that wrote after she had given birth. I served as her doula, and after she had given birth, she was in the labor and delivery room, and at midnight, the nurses told her she had to go to the postpartum floor. And no one helped her. No one supported her. She was pushing both her IV and the baby in the little isolette. And her husband was carrying all of their stuff. And this is the poem that she wrote called Moving to the Postpartum Floor. Feels like a demotion. Feels like I did something wrong. No longer are they waiting on me hand and foot. Step careful, cautious. It's midnight, and they made me push my baby, newborn, just yesterday. Don't look behind me, but I know hubby's there, carrying 10,000 bags. What in the bootleg nativity is this? New room has a neighbor? mommy and baby behind a curtain. Her baby, sleep, my baby up, my baby sleep, her baby up every couple of hours to feed, to take a new test. Nice nurses, not nice nurses. Press my breasts hard, press my arms hard, begging for my milk and my blood. Such sacrifice. I want to go home, want to go make a home. Hospitals are not homes. In the meantime, I search for Google images of Tupac breaking out of Bellevue. It's right down the street, but feels boroughs away. Anyway, Pac knew a hospital is not home. I too plot our escape, or dream of a baby's Uber ride, or freak out about baby girl's first Uber ride, or dream about home, apartment, box in Brooklyn, and the mother who I will grow into being there.
Thank you for reading that.
My pleasure.
What does that poem express that are central themes to your book?
So first I'll say that LeConte's story does not appear in my book. I interviewed her and spent time with her after the book was published. But I lay out in the book the dimensions of obstetric racism, and her poem illustrates the frustration of the kind of experiences that Black women have in hospital settings, where they feel uncared for, where they feel dismissed or neglected, all of which are things that LeConte experienced in the hospital. And in fact, she experienced those similar things while she was attempting to conceive because she had assisted reproduction. And so I think her poem really sheds light on how complicated it is to be in a setting after you've done one of the most important things in your life, and then to have people, which is in her case giving birth, and then to have people treat you so dismissively, and to move you along, I think, in cattle fashion so that they can use the bed for the next person.
I know from my wife's work, she's a former NICU nurse and labor and delivery nurse, and is currently a public health nurse. And so I've heard of the staggering numbers of increases of infant, mortality, C-section, all of the different types of outcomes and treatment that African Americans get compared to white dominant culture. And I was wondering if you can share some of those updated numbers, just to let everyone know how significant this issue is.
Well, the updated numbers should be out every year in November, which is Prematurity Awareness Month. The March of Dimes does a premature birth card. It's called a premature birth rate card.
Mm-hmm.
And what they're doing is rating each state, giving it a grade for their ability or inability to reduce the premature birth rate. Now, premature birth rates are really important because prematurity is one of the most common causes of infant mortality. And so in the U.S., so first of all, the March of Dimes originally they wanted to have a premature birth rate of 8%. And now, and the U.S. was on a downward trend, which was good. And then I think maybe I feel like it might have been about 2016, there were these incremental increases in premature birth rates. And now we are unfortunately at 10%, which makes us, the US, one of the worst places to have a baby.
Mm-hmm.
But for Black women, the premature birth rate, like Black women are maybe 40 to 45% more likely to give birth prematurely.
That's huge.
It is huge. And, worldwide, it's interestingly, it's the same thing. So in Great Britain, Black women, so other indices are maternal mortality. In the UK, a Black woman is 8 times more likely to die as a result of a pregnancy-related cause than other women. In New York City, where I am, Black women are 3 to 4 times more likely to die as a result of pregnancy-related causes. Ideally, the C-section rate should be really low, like, I don't know, should be something like 6-7%. It's 30%. And Black women are more likely to have C-sections in the U.S. than any other group of women.
So it's 30% for all women in America generally, and then an increase, an increase with Black women.
And we just have this incredibly high C-section rate. The disparities are evident in the data, and people use those numbers to talk about disparity. But one of the things that I'm really interested in talking about is it's not just a disparity. There is racism at work, because we have been, in the United States at least, attempting to address maternal mortality and infant mortality since the 1910s, when the Children's Bureau was started. And despite all efforts, Black people's rate of infant mortality, maternal mortality, premature birth continues to be consistently higher. Now, maternal prenatal care is really supposed to address these incongruencies. And we have to ask ourselves, what's up with our prenatal care if we still end up having such horrible outcomes for particular groups of people? And I'm just unwilling to accept the fact that there's something inherently wrong with groups of people. I just don't think that's true. What I think is true is that the medical profession has developed its skill in obstetrics and gynecology literally on the bodies of Black women who were enslaved, and that some of the ideas about those bodies as being hardy, as being capable of tolerating pain, all kinds of things. I think that those ideas from that past have migrated to the present.
Well, and as less than, I imagine, is on that list.
Yeah, of course. Yeah.
You talked about, despite all of these efforts since the 1910s, I have to ask, what has been the totality of, quote, all these efforts? Have there been significant efforts that have been thwarted, or, hey guys, where are all these efforts? We know this information. Why aren't we doing much about it?
I think one of the things that I think is, first of all, a lot of the efforts to save babies and to save women and birthing people in the 1910s, it really was rooted in a eugenic perspective. It was about saving white babies and saving white women. if we look really closely at the people who were crafting programs through projects like the Townsend Act and uh, trying to get milk, for example, milk stations to people so that their babies would be stronger. Like they really were focused on trying to save white infants, which was also linked to the fact that like Irish people and Italian people and Black people didn't have the skill to take care of themselves, and so they kind of need help. But and the other thing is, so what I'm saying is on the one hand, a lot of these efforts from the early part of the 1900s was in fact about saving whiteness, preserving it. But the other thing is that I really think technology has driven a kind of diagnostic dependency where we just think everything can be addressed by diagnosis, by using fetal monitors. Fetal monitors will show you what a baby's heart rate is doing, but do you need to freak out when it drops a little? Probably not. They could be just moving, or when it raises a little, they could just be moving. But we use those technologies to develop certain kinds of interventions. And it's fascinating to me that during COVID, more babies were born at term. This was internationally than has happened in quite some time. And why is that? People actually weren't going to the doctor so much. They weren't going into hospital settings so much. I'm not saying that they were having home births, but because, people who go to hospitals for their care, for their, to go to their doctor in the practice, they didn't want people going into hospitals. And there was a lot of telecare. So that means that people weren't getting all of the interventions that might typically lead to a particular kind of diagnosis, that might lead to, let's do an induction. Oh, let's do a C-section. Oh, that kind of thing.
Yeah.
So I have to wonder about the role of technology in saving babies and people, and why we use technology to intervene when we probably would do better by using preventive methods, such as letting people labor at home as long as possible, such as providing different kinds of prenatal care, such as, making sure people have, like maybe people could take their own blood pressure at home. Maybe their blood pressure is high because they're at the doctor and they have white coat syndrome.
I'm hearing the doula in you speaking as well.
It's true.
Yeah.
It is true.
What I'm hearing is the intersection through obstetric, racism, and technology. That intersection is a perfect storm or a bad combination.
I don't want people to get the impression that I think technology is not useful. I just think we have an overdependence on technology, and that there may be some link between the overdependence on technology and the way particular bodies get viewed that result in certain kinds of interventions. If you already believe as an obstetrician that a Black body is going to quote naturally have a baby early because that's what happens with Black people, and you use technology to make decisions about blood pressure rates and so forth, and then you end up possibly having a particular kind of diagnosis that will confirm. You'll use technology to confirm your diagnostic predilection, right? Or prediction. And so I know people who, large Black women, they say, oh, because they think a person is large, they think, oh, you must have high blood pressure. That's not always the case. Not every Black person has high blood pressure. I can't tell you the number of times obstetricians will say, oh, you're large, you're probably going to end up with high blood pressure, also known as preeclampsia. And we're probably going to have to do a C-section. Oh, let me take your blood pressure. Let me take your blood pressure. Let me take your blood pressure. Let me do
and the blood pressure goes up. It all goes up. Yeah.
Right. It goes up, maybe. And then they start preparing the patient for thinking that they might start preparing the patient for thinking that they may have to have a C-section, which in and of itself can create stress, which could raise your blood pressure. So, I mean, I've actually seen that happen. Again, I'm not saying that technology is bad. I am simply saying that we would probably be more successful in reducing rates of infant mortality and maternal mortality if we did more preventive work, if we offered post-birth opportunities for people to stay home and heal, that in the postpartum phase, people got 40 days or 60 days to just be supported and heal. I don't know about you. When I was a kid, when my sister was born in 1963, like a nurse came to our house.
Yeah.
And helped my mom out.
Okay, I got a funny story about that. So when my brother was born in 1973, Lucy, the nurse, came to the house. I'm told all this. And I was about 2 years or so older. And after the few days when Lucy left, actually, I have this image of Lucy wearing white nursing garb, right? So I don't know if I've made that up or that's real. It seemed like, old school nursing. So she's leaving, and apparently I ran after her, toddled after her, and I said, Lucy, you forgot the baby.
That's really funny.
But that was normal.
That was really normal. Funny. Yeah. Right. Where is that? Where is that support?
Yeah.
And people can have babies at term if they receive support. That's what group prenatal care can do. People can, I think people just need more support during pregnancy and after pregnancy, during conception and after conception. And it doesn't have to be that deep. It doesn't have to depend on, ultrasounds or sonograms.
In terms of raising awareness, which your book is about, raising awareness on obstetric racism, I want to highlight the different types that you identify for your comment. So we have diagnostic lapses, neglect, dismissiveness, or disrespect, intentionally causing pain, coercion, ceremonies of degradation, medical abuse, and racial reconnaissance.
Yes.
That's a lot of stuff going on. And as I have read in subtle and not so subtle ways constantly. Are there any of those which you wished to highlight for our listeners? I know they're all important, but what do we all need to be aware of that occurs? And also what to look for our listeners, for themselves or their loved ones being in the situation of birth and hospitals?
Sure. I do think that diagnostic lapses occur. That's actually expressed, or an example of that is what I described before, talking about, a Black woman, for example, who is large, and the presumption is that she's going to require, or that she's going to end up with high blood pressure, and that they may require a C-section. That's a diagnostic lapse. It's because there's some belief that Blackness is pathological that leads to an exaggeration of what the outcome is going to be. I do think that people need to be the most common thing I think happens is neglect, dismissiveness, or disrespect. I think that happens because the medical professionals do not believe that patients understand their own bodies. It is fascinating to me the number of times a person will say, I had a sense that something was wrong and they didn't pay attention. They didn't listen to me or they, pushed aside my concerns. It is unbelievable. And what that means to me is that patients in a hospitalist or medical setting need to assert
Mm-hmm.
themselves and need to come fully prepared to defend what they perceive as being the thing that's the
Mm-hmm.
problem. And even if they are wrong about what is wrong with
Mm-hmm.
them, that does not mean that they do not deserve to be treated with respect.
And is that possible with a woman, a Black woman, alone in the experience? I just uh, imagine multitudes of overwhelm,
Right.
versus having a partner, some other family member, a doula.
Hmm.
These are all like ways to layer in support to prevent these situations and have someone to
Right.
advocate for you.
Right. I mean, I think everybody going to see a doctor should have a person with them. We all need witnesses. When my mother got diagnosed with having lung cancer, she couldn't hear what they were saying to her. And so, we were there taking notes. And that helps. What that suggests to me is that people always need patient advocates, family members, just another witness, a support
Mm-hmm.
person for everything.
Mm-hmm.
Um, in this fast-paced world with all of these technological apparatus and testing and so forth, it's really helpful to have somebody else to bounce that kind of stuff
Mm-hmm.
off
Mm-hmm.
of. But it also can help you afterwards when you're leaving a
Yeah.
particular medical encounter and you just want to be like, oh, wait, what did they
Mm-hmm.
say?
Yes. Very hard to be the patient.
Um,
In it,
I think
Yeah,
so.
and in pain, but and in overwhelm, in fear, and in all of the situations.
Sure,
So you spent 6 years interviewing your people for your book, yes?
I did.
What I'm
It's kind of
wondering
crazy.
about is, as an expert in the field, and as you embarked on this project, what did you end up learning or finding out or becoming aware of that you either didn't expect or
Mm.
weren't previously aware of?
Oh, um, I don't think I expected the subtle narrations of racism. I didn't, I mean, I know what racism looks like. I've experienced it. I didn't expect people, birthing people, would say that something felt like it was racist and that they could also make a reference to the past, meaning, so this didn't happen I don't talk about it in my book, but I've done focus groups with people since. But sometimes women will say things like, oh, I had a baby and afterwards I felt like I was on a plantation, like the fact that they were being forced to do certain things. And I just found that constant reference back to the past, to the historical past of what Black people's lives have been like in the United States, really, really fascinating. I also did not expect, and what I learned was about the thing that I call racial refusal, which was on the part of medical professionals, particularly NICU chiefs of NICU departments and neonatologists who simply refused to acknowledge or talk about race, but then proceeded to use euphemisms that reflected on race. Um, and I think it was, I found that somewhat surprising. Yeah.
It brings me to the purpose of your book. What would you say, is and has become the purpose of your book, your hopes for this work?
So, interestingly, I had hoped that the book would undo things. I had hoped that people would unlearn the way that society has pigeonholed poor and low income Black people as being responsible for their own health and birth outcomes. I hope that when people read this book, they understand that there might be any number of reasons that adverse birth outcomes occur among Blacks. But one of the reasons that we need to look at and that we must attend to is the role that is specifically played by the medical complex. I am absolutely unwilling to not have that factor in our accounting of why we have these birth outcomes. I mean, I think Serena Williams is a really good example of that whole expression of neglect and dismissiveness where they weren't paying attention to her. That was not because she had something wrong with her or she wasn't compliant. It was because the medical professionals refused to believe her own assessment of her body. I had wanted people to realize that Black people with lots of degrees of capital, like access to insurance and higher degrees of education, that they experience racism too, right? I wanted people, and I think another goal of the book is that I'm critiquing the idea of the medical complex, that we think that every single thing in pregnancy and pregnancy must be medicalized at the expense of having a more expansive view of pregnancy and birthing options. Not everybody needs to give birth in a hospital. People could do it at home. They could do it at birthing centers. And that's not to say that I think that there's no place for medicine. I just think we need to have more options. And I think finally, I had one goal was for medical providers to unlearn their own insistence on their expertise. Like their expertise needs to be mediated by the fact that people understand their own bodies.
So what are you hearing from this community thus far about your book?
Oddly, it's being very well received.
Oh, wonderful.
I would not have expected that.
That's wonderful. Yeah.
And I have been working with an OBGYN epidemiologist, Karen A. Scott, who has taken the obstetric racism framework and turned it into what's called a patient-reported experience measure, making it the only validated measure of Black women's experiences in hospital settings.
Nice.
And using it to get hospitals to recognize that racism probably circulates and how and in what domains. And, it's hospitals are excited about that work. And
that's wonderful. That's wonderful.
They're interested in learning about what it is they can do to shift.
That is awesome. Your goals are in the process of being met. And that leads me to the final question prior to our final question. And that is for all of us, everyone listening. What are actions that the everyday person can take to raise awareness, to make a difference with obstetric racism?
Well, I think that there needs to be more community involvement in getting permissions for birthing centers, which can be really, really complicated. It's like trying to scale the gates to get into the White House, which, well, that's not a good analogy.
Not anymore. Yeah.
Not anymore, but okay, used to be. And, you know, I was just talking to somebody recently who said, I don't remember what state they were in, but we need to make it more accessible for there to be practicing midwives. Not every midwife needs to be a nurse, right? So opening up options, I think. And I think people really need to focus on some kind of healthcare system that will allow for comprehensive care and reimbursements. I mean, I actually really believe in universal healthcare. I think it's the only way that we're going to close a kind of health gap.
And in just the trajectory of, premature children and the medical costs, the medical care, the medical issues, the learning and processing challenges. I mean, there's lots of ways to get all that, but it's the beginning of life. Assuming the life occurs, it's the beginning of life, and so critical. Okay, Dawn, it's time for the parent footprint moment question.
Okay.
Here we go. Tell us about a time that you became aware of yourself as an individual, as a parent, or an awareness of your parents, and that new awareness had a positive impact on yourself, your child, or your life.
Okay. So, I think maybe when I was 5, my mother went to Europe for a month, and I stayed with my grandparents and my father. And my mother has always been she's literally a world traveler. And my father refused to fly. I think he flew one time in my entire life. But what he did was he always supported her trips. He was so wonderful about supporting her trips. So what I learned was, as a person, I learned be curious, go places, enjoy yourself, and don't let anything stop you, even if you have a husband or a partner. But I think I also learned that in relationships, intimate relationships, when a person can be really joyful for you and really support you in the thing that you want to do, that's like the gift, a magnificent gift. And so I guess I strive to have relationships like that.
Yes, that is so powerful, so insightful, and also just shows how impressionable we are, humans, as children. Like, age 5, you had this awareness, which then you got to see, it sounds like, from your parents several times, this dynamic play out. But
at least twice a year.
But it sticks with you at 5. And I just think that's beautiful. The idea of a partner, the strong bond that you are excited and supportive of your partner, even when they are going in a place where you are literally or figuratively not going yourself.
Yeah.
Well, thank you for sharing that moment and sharing your experience and your lived wisdom and scholarship. Tell everyone where they can find your new piece of work, Reproductive Injustice, and all of your others as well.
So, Reproductive Injustice, Racism, Pregnancy, and Premature Birth is published by NYU Press, New York University Press, and you can go on their website. My other book I have another book with Krista Craven called Feminist Ethnography. That's published by Rowman and Littlefield. We have 2 books published with them. And my first book, Battered Black Women and Welfare Reform Between a Rock and a Hard Place, was published by SUNY Press. So I encourage people to go to the university websites to get the book.
Thank you. And for those who can't see, Donna and I looking at each other, she gave me a little wink because before the show, I was educated on how to pronounce the difference between CUNY and SUNY and how they are separate. So anyways, I am now educated in other ways as well. So thank you for that.
You're very welcome.
All right, everyone. That concludes another insightful and important show and topic. If you want more of Parent Footprint with Dr. Dan, check out our bonus episodes once a month exclusively on Stitcher Premium. To listen, just go to stitcherpremium.com/Dr. Dan, click Start Free Trial, select a monthly plan, and sign up with the code Dr. Dan, and you'll get a month of free listening. You know what I'm going to ask you to do. It's simple to say, it's hard to do. That is to be the person, try to be the person you want your child to become. And ask yourself the question I ask myself every day: what footprint do you want to leave? This has been a Peters and Rossi production. Parent Footprint with Dr. Dan is produced by Laura Rossi. Our engineer is Phil Rossi. Theme music is Strummerman, composed and performed by ProTunes. Artwork is by Garrett Ross. Follow us on Instagram and Facebook at Parent Footprint Podcast and on Twitter at Dr. Dan Peters. If you are an advertiser interested in advertising on our show, go to midroll.com/ads. For more information, go to exactlyrightmedia.com. Listen, subscribe, and leave us a review on Apple Podcasts, Stitcher, or wherever you get your podcasts.